Okay, so today we're going to talk about upper GI disorders, chapter 45 in your med-surg book. First one we're going to discuss is anorexia, and this is a lack of appetite. There's different things that can cause anorexia: emotional, it can be drug-related, fear, stress, psychological, illness. All of those things can cause it. Sometimes you get stressed out and you don't eat. Other people get stressed out and they eat. So many things can cause anorexia, though. Hunger is absent. The client just has no desire for food. And if it's less than a week, there's really no intervention that's necessary. Your body is okay. But if it's persistent and it continues past longer than a week, then you may need supplemental feedings, high-calorie foods. And if it goes on for a very long time, it's more than likely a psychological disorder, and you will need psychological support and even rehab with that. Nursing, we're going to maintain adequate nutrition, and we're going to monitor the weight. We're going to refer to counseling, especially if we think it is a psychological need. Nausea and vomiting. This is common causes, can be drugs, infections, inflammation of the GI tract, intestinal obstruction, food poisoning, emotional stress, early pregnancy. That first trimester you have a lot of nausea, vomiting, and uremia. For this, we're going to monitor dehydration, especially if nausea and vomiting is present. We want to make sure that those electrolytes are still getting back into the system, that they're not getting dehydrated. If they're not able to take food or drinks by mouth, then we might have to start an IV on them. We're going to administer antiemetics and IV fluids, electrolyte replacement as needed, depending on the severity of the dehydration. As a nurse, you maintain nutrition and hydration, so you'll probably start an IV and get some fluids going. Again, if they're vomiting, you probably don't want to administer any kind of pills, so you can do some antiemetics that are IV as well. For oral cancer, it's twice as high in men than women, and usually that's because men do more of the chewing tobaccos and things like that. Early stage is usually asymptomatic. They don't have any symptoms, and then it comes on later and more ferocious. Risk factors, the major risk factor will be that tobacco use, alcohol consumption, prolonged sunlight exposure. All of those can cause oral cancers. It may develop anywhere on the oral mucosa, including the lips, the tongue, and the pharynx. So here you can see a picture of it right there on the side tongue. Basically, the assessment is that it's a sore in the mouth that just will not heal. You can see irregular white patches, slightly raised irregular red patches that bleed easily when scraped, visible or palpable masses. They often have a sore throat or just a feeling that something is caught in their throat and they can't get it down. Diagnostics will be with a biopsy, so they will get a biopsy and those cells will come back malignant. The treatment is going to be eliminating those risk factors. What caused it? If it was tobacco, smoking, then of course we want to eliminate that. A lot of times the treatment will be kind of a combination of radiation, chemotherapy, and resection, some kind of surgery, extensive surgery, going in and removing that. A lot of times it will leave their face looking very disfigured and disformed. Airway is going to be very important. We want to make sure we're suctioning them, turning the head side to the side to make sure that they're not going to aspirate on any blood or anything like that. Food, fluid intake, communication, they're not really going to be able to speak with you, so we have to make sure that we're taking care of them in that way and giving them something to write, or making sure that they're able to read our lips or talk slowly, talk loudly. And then as for them to be able to communicate back with us, just give them a pen and paper and let them write it down. We want to respond promptly to them, and we have to give them a lot of emotional support. Like I said, a lot of times this is going to leave them looking very disfigured, so they'll need emotional support. They'll probably need some counseling, and to just be able to facilitate that and get them to where they need to go. Upper GI disorders, we're going to talk about a little bit about tube feedings. You will be responsible for administering tube feedings, the management of those tubes. If you'll look in your book at page 720, you'll see all the different types of tube feeds. Any kind of charts or graphs in your book like that, you really need to look at them, read through them, understand them. When we're talking about an NG tube or a nasogastric tube, that obviously goes right through the nose into the gastric area, into your stomach. You can place a Dopphoff. With this, it's going to be checked by x-ray and auscultation. Of course, x-ray is always going to be the best for initial placement. Once we get confirmation by x-ray, it's not feasible to continue ordering x-rays every time you need to check placement. So after that, we're going to listen to it. We're going to osculate. We can also check pH balance, aspirate those pH contents of the stomach. But typically what you're going to see in the hospital setting will be checkment first by x-ray and then after that auscultation. So with the G-tube, that's the gastronomy tube, and that's going into the actual stomach. It's placed directly into the stomach. A lot of times you'll see that it's called a PEG tube, percutaneous endoscopic gastronomy. It's going to be right there on the stomach. It's going to go directly into the stomach, but it's going to be on your abdomen. You'll see it like a flash. It might have a little tube sticking out of it, or it might be like a button. And so there's just different ways that you can see that. There is a good picture of one on 723 in your book, figure 45-2. You'll also see where there's like bumpers on that tube. Those bumpers just kind of keep that tube in placement. Whenever we're looking at those tubes, we have to take really good care of them. We want to make sure that there isn't any kind of gastric acid leaking onto the skin. We're looking at our skin, making sure there aren't any ulcerations, any bleeding, any pus, any infection, anything like that. So we're checking that really good as well. Going back to those bumpers, the things that actually hold it in place, sometimes they can be too loose or sometimes they can be too tight. And when that happens, that can cause ulcerations in the stomach and in the stomach wall or even on the skin on the outside. So we want to be real careful and watch that. A J-tube, it's going to be placed directly into the jejunum, so that is right directly into the small intestine. And when we're talking about that, a lot of times you will not do any kind of bolus feedings when you have a tube placed directly into the jejunum. Anything below that pyloric sphincter, remember the stomach, you have the stomach, and then you have the pyloric sphincter at the end. If that tube is below that pyloric sphincter, we're not going to do a bolus feeding, and the reason behind that is because it's going to cause them cramping. So you think about it, when you have the stomach, you have kind of a reservation, but whenever it goes directly into the small intestine, you just have small tubes that will cause a lot of cramping and discomfort for them. So we need to know where that tube is actually placed and keep that in mind as well. When we're managing tube feeds, you can have 250 to 400 mils. You can do a bolus, which would be anywhere from 15 to 30 minutes, just kind of pushing it in. You can have intermittent, 30 to 60 minutes, or you can have continuous, where it runs all night or all day. They might cut it off at night, cyclic, 8 to 12 hours, and usually that is ran at night. So there's a lot of different ways that you can do their tube feedings, and the doctors will order that, so you check the orders and see what they want. Of course, anytime before you ever use a tube feeding, before you ever administer anything into the tube feeding, you want to check placement. And the easiest, fastest way for a nurse to check placement will be auscultation. So you listen, you give them an air bolus into the stomach, and you should hear a whoosh into the stomach, and you know that it's in the right area. Okay, placement first will be x-ray. That's our diagnostic, that's our first line, but after that, auscultation. You can also aspirate the pH, the fluid, and check the pH balance as well. So aspirating prior to feeding is just to check that residual. Say that you have already given a bolus of food 2 or 3 hours ago, and if you go back to check residual, what you're doing is seeing how well that food traveled through the stomach, the intestines, how well it's being absorbed. If that residual is greater than 100 mils when you check it, when you go back to check it, you're not going to give them another bolus, because all that's going to do is sit there in the stomach. And if there's anything sitting there, pulling there, automatically you think about infection. So we don't want to do that. So if there's greater than 100 mils, we're going to re-administer it. We're not going to take it out and dump it somewhere. We're going to put it back in because we need that pH level to stay constant in that stomach. So we'll re-administer it, and we're going to delay our next feeding. We're not going to go ahead and give that bolus feeding. And then, of course, you chart that. Residual was 100 mils, re-administered it, hold feeding for an hour. So with our tubes, of course, there is the obvious for feeding, but we also will administer tubes for GI decompression. And this is going to be the removal of gas or fluids from the stomach. So it can be that the patient is just vomiting a lot and we just need to get whatever is on the stomach out of there. It could be that they're bleeding and we need to get that blood out of the stomach. So sometimes we'll use nasogastric tubes or our different tubes, and we'll hook them up to suction, and we'll use it for decompression of that stomach, getting those fluids, getting gases out of the stomach. When you're looking at an NG tube, if you're going to place one for decompression, you're going to be using a larger lumen tube. It's going to help serve as a vent and draw out that excess air. Also, if there's any larger pieces, it'll just be able to pull that out better. For tube feedings, a lot of times you can use the smaller tube feedings. It's going to feel better on the nose, and it won't bother them quite as well. But for decompression, you use those larger lumens. Major complication is going to be leaking from that vented lumen. To prevent leaking, make sure you keep the head of the bed elevated at least 30 degrees. Nurse of clients with the GI tubes. We want to monitor our patients very closely. We're going to check output from the suction, and we're going to document. Eyes and nose are very important. So when you're out in clinicals, make sure that you're looking at every time you go in there. If that patient is taking a drink, we're charting that. Everything that goes into that patient's body, we're charting. Everything that comes out of that patient's body, we're charting. So that also includes any kind of suction or anything like that. We're also looking at the color of it. What does it look like? What's the consistency of it? And we're monitoring and documenting that as well. We're going to be monitoring their weights, seeing if there is any kind of imbalance in that. If there's fluid excess, we expect that there will be an increase in their weight. We'll monitor the drainage. We're going to prevent any kind of skin breakdown. Like I said, if that tube accidentally comes out and we start leaking gastric fluids, that's going to eat away at your skin really quickly, and it can cause ulceration. So if that GI tube, whatever it is, accidentally gets removed, this necessitates an immediate replacement. We want to go ahead and stick it back in as much as we can, and we need to notify the physician immediately, okay? We're not going to use that tube at all because we know that it might not have gone back into the right place, but at least we'll keep that hole open until the physician can get there and replace it completely. A lot of times with the new GI tubes, it won't go right back into place. If it's an established tract, though, a lot of times we can insert a Foley to maintain the patency, inflate that balloon, and it will maintain that patency until the G tube is replaced by the doctor. With GERD, it's gastroesophageal reflux disease, and I'm sure we've all experienced the symptoms of it. With that, it's only a disease whenever it becomes very chronic or you have ongoing symptoms of it. It's more, it's considered a disease process only when it's excessive or causes a lot of pain or respiratory distress. Otherwise, we consider GERD more of a symptom. So it develops when gastric contents flow back up into the esophagus, and everyone's experienced it. It's real uncomfortable, but it's caused by the inability of that cardiac sphincter to close fully. It can lead to esophageal stricturing, which is closing of that esophagus, just kind of narrowing. It can lead to esophageal cancer, especially if it's really severe or chronic. Obesity and pregnancy are going to increase your likelihood to get it just because of all that extra pressure on the diaphragm. If you're pregnant, you have that baby pushing up on that diaphragm. And if you're overweight, then you have that excess fat pushing up on that diaphragm as well. Signs and symptoms, you're going to have epigastric pain, discomfort. it does have to, we do have to rule out an MI because you can have that same symptoms, feel that same thing. It can be aggravated by bending over or lying down. You'll have difficulty swallowing, esophagitis, irritation in the esophagus. You could actually, it could be so irritated and inflamed that it starts bleeding, and then you might be spitting up blood. Melena, which is a tarry stool, so there could be blood in the stool. Just a feeling that there's something stuck in your throat, and you could even get aspiration pneumonia as well. Diagnostics for it will be a barium swallow. It's going to show the inflammation or the stricture, which again is kind of that narrowing, that closure. Stool test can show blood. If it is causing bleeding and you're bleeding in the stool, then we can do a stool sample and see that there is blood in the stool. The EGD, the upper endoscopy, is going to actually be our confirmation of diagnosis, where we can actually see that. Remember, with the EGD, they're going in through your mouth, down into your esophagus, and looking with a scope, a camera, and so they're actually able to see that really well. Treatment, we're going to educate. We're going to tell them to stop smoking because that definitely aggravates those cell tissues. Avoid eating or drinking 2 to 3 hours before bedtime. Elevate the head of the bed when sleeping. Sometimes just sitting up a little bit, getting that head of the bed up 30 degrees is going to help keep those acids more controlled and in the stomach. Avoiding foods and drinks that intensify those symptoms, whether it's real spicy food or caffeine. Avoiding foods that lower the pressure in the lower esophagus, cardiac sphincter, caffeine, alcohol, peppermint, citrus, and high-fat foods, and licorice, which I don't like licorice, but anyways. The other treatment for GERD is going to be just kind of medications. And with the medications, you have a lot of medications, so you do need to be looking at those. In your book, it says 726. So with H2 antagonists, what the H2 antagonists are going to do is basically they're going to inhibit or suppress that gastric acid. Okay, we give it after meals and at night as needed. And your H2 antagonists are going to end in DINE, okay? So whenever we're looking at these drugs, we don't want to go directly to the trade names. Oh yeah, Pepcid, Xanax, Tagamet. Oh, I know all those. That is not what NCLEX will be asking you about. They're going to be asking you about the harder, more difficult names, which are also more difficult to say. But the nice thing about this is all the H2 antagonists are going to end in DINE. So there's your cheat right there. You can figure it out and know what they're going to end in. Okay, moving on, the proton pump inhibitors. Proton pump inhibitors, again, we're not going to ask you Protonix, Prilosec, Prevacid. Those are real easy to remember and even easy to say, but we're going to ask you the more difficult names. You know, they want to make us look silly when we're trying to say them. So Omeprazole and Lansoprazole and Pantoloprozole. But the good thing is they all end in ZOLE. So you can remember them that way. Proton pump inhibitors end in the ZOLE. They are going to suppress that gastric acid, and we want to get those before the meals. So suppressing that acid before we actually take and eat anything. The antacids, those are also really great, and a lot of those you're going to find over the counter. Magnesium hydroxide, the Mylanta, the Tums, the Maalox, sodium bicarbonate, aluminum hydroxide, and those we can give after meals and as needed. GI motility agents, this is going to be Reglan or metoclopramide, and it's going to stimulate gastric emptying. So it's going to speed that stomach up and just kind of get those gastric contents moved on out of the stomach. Okay, if these medications do not work in treating the symptoms of GERD, then we can do a fundoplication, and that is basically a surgery that just tightens that cardiac sphincter. Remember, the cardiac sphincter is at the top of the stomach. So they'll go in and they'll tighten that, and sutures are left in place, but that kind of tightens that up. All right, we're going to stop right here, and we'll cover this one next go round.